Hi, everybody. Can you hear me okay? It's live and we can start. Hey, everybody. It's Sherry Bauer-Gagne, Parkinson's Parkinson Awareness Client Services Coordinator out in the Lloydminster region. Emma's down here laughing. We're just waiting for Dr. Ba. Hopefully we'll see her shortly, but we wanted to talk a little bit about Parkinson's Awareness Month. It's April, and of course, April 11th is Parkinson's Awareness Day. So just curious about what everybody's doing in the province for Parkinson's awareness. Calgary's got a bunch of stuff going on. Edmonton had some stuff going on. Lloydminster had some stuff going on. Of course, with COVID-19, that really shut us down for a lot of our plans. So we've been busy talking to clients and individuals out in the area. I feel like I'm talking to myself. Emma, how about coming on and talking with me a little bit here?
Yeah, so for the month of April, we've got lots going on for Parkinson Awareness Month. We have weekly webinars on Wednesdays, and so this is one of them, and then they'll continue for the rest of April and into May, which is exciting. And then on Mondays, we have our Motivation Monday. So there's different exercises that folks can follow along with, and then they're always available on YouTube afterwards for people to view if you can't view it live. And Fridays, we're calling them Freestyle Fridays. And so there's something different every Friday to kind of get into your more creative side. And so this Friday, we have something musical from Ashley in Edmonton. So that's exciting. So there's always something happening, and the best way to stay up to date is look at the program calendar that's put on the website, and that one's updated as we update our information. So that's the best place to look.
Hopefully everybody was able to attend the sleep one this afternoon. Well, hi, Dr. Ba. Welcome.
Hey, sorry about that.
Hey.
I don't know why it asked me to install Zoom again. I have been using Zoom for quite a while, and then today it might be a different version whatsoever. It's not university, not AHS, so that's probably the reason I have to redo the software. So sorry about the delay.
Well, that's okay. Well, we're all learning these little tricks of the trade. We've got Nicola here kind of giving us some help on the back end, and I've got my team to support me, Ashley and Emma from Calgary and Edmonton. They're here to support us, and Nicola's in Edmonton. So
Hi.
Yeah, so I'm going to introduce you, and then we can take off. We're really excited to hear what you have to tell us. All right, so my name is Sherry Bauer-Gagne. I'm the Client Services Coordinator for the Parkinson Association of Alberta out in the Lloydminster region. And so we'd like to welcome our special guest, Dr. Ba. She's a neurologist with the Parkinson and Movement Disorders Program in the University of Alberta's Kaye Clinic in Edmonton. And Dr. Ba received her degree from the University of Calgary in 2007, and she obtained her PhD in physiology and neuroscience from the University of Alberta. She finished her neurology residency and CIHR fellowship in movement disorders at the University of Alberta, where she's pursued further training in deep brain stimulation, DBS, at the University of Florida. Her research interest and practice are in DBS for movement disorders, and she is currently the assistant professor in the Division of the Neurology in the University of Alberta. Now, we have quite a few clients that we know that have had the deep brain stimulation and with really good success. So welcome, thank you for joining us, and we're really excited what you have to say to us today.
And I apologize again about being late. I actually have a pretty good reputation of never being late. It's really my fault. So I'm going to share my screen and with my PowerPoint presentation talking about the research we are doing at University of Alberta. Can you guys see that? Okay, that's good. So I'm talking about clinical research of Parkinson's disease in our institute. And I'm going to talk step by step. And first introduce a little bit about what is clinical research and why do we get involved in research from the patient perspective. And then later part of the talk, I'm going to mention about what kind of research we're doing at U of A. I don't think I can cover all research topics within an hour or 15 minutes. I'll just give some examples about the type of work we do and the different focus in our research areas. So what is research? You know, everything there is a definition. Research, by definition, is a systemic approach to obtain new and reliable knowledge. It's kind of formal, right? It's the evening talk. Nobody wants to really go to the definition kind of thing. So basically, research is you have a question you want to do is in a systemic way through an approach to solve this problem. By doing so, you need to go through collecting of the data, analysis of the data, and then put in the right way to interpret of the data and lead to the answer of your question. So that is the research. So why do we do research? It's not we have a lot of money, you know, we hire research people, do nothing but stay in the lab and do research. Research, there are different objectives, different goals. So to do research is to determine what is normal and to determine normal from abnormal and to determine the association between different phenomena with these abnormal findings and what cause the abnormalities. And when we have an entity, a disease, then we test the new intervention, new treatment. So that's all parts of the research. And so in summary is to explore strange phenomena, seek out the truth, and to boldly go no one has gone before. Obviously, that doesn't sound like me. Actually, this is from Star Trek. To explore strange new world, to seek out new life and new civilization, to boldly go where no man has gone before. So this is the same philosophy of doing research. And the end result of doing research is to lead us to a better area for improvement of quality of life in clinical research. So most of us, although like some had basic science trainings, at this stage, we are doing clinical research. And from clinical research, actually, is a long way from basic science. So people do a whole bunch of basic science research in the lab, to cultures, to animal behavior. And from there, we design the phase 1, phase 2 studies, for example, to test the safety of a new drug, and then put into a clinical research to test what kind of effect on human after safety is established. And then from there, try to translate into practice to see what kind of benefit in the treatment and improve health as the outcome for the final goal. Why patients always ask, you guys ask me, come to see me, and we're doing a whole bunch of research, and there's a list of research ongoing, and we even post a couple things, links on the Parkinson Alberta website. And patients ask, why do I want to get involved in research? So these days we practice patient-centered medicine. And the goal of that is to improve to the patient healthcare, right? To provide the best healthcare for each individual person. And we take patient's goal, preference, and the value into the account. It's not for me, it's for the patient. That's patient-centered. Whatever decision we make is not what I tell patient to do, right? It's a shared decision-making process. Patient-centered medicine cannot be practiced without patient input. So when patients getting involved in their healthcare research, they're always making their own decisions, and research is part of it. So you have the opportunity to know what's going on in the front line, and these research, these results will inform the further decision in healthcare measures. And also it's different than say 20, 30 years ago. Doesn't matter if it's research or clinical practice, it is the true partnership between the patient and the physicians or the researchers. So this is research with the patient, is no longer research on the patient. Patient is not a subject, patient is our partners in research. So for example, when I submit a research proposal, doesn't matter to a research agency or to our research office at university, it has to be a scientific relevant research proposal. Otherwise, they turn down right away if it doesn't make sense, right? But patient will ask, are they relevant for my own health? Are they relevant from my perspectives? So that is very essential, looking at achieve the translational goal for the research. Like I can ask an imaging biomarker and all kind of fancy sequence of an imaging, like MRI, but patient will ask me, what does it mean to me, right? If it has nothing to do with the clinical practice, with better detecting of the disease, better prognostic of the disease, there's no point of doing the research. So when people ask us, why do I get involved in the research? And this is very crucial for us to understand. We need to identify the question they ask, and we need to address the outcome. And is patient-centered again. The outcome is for patient to understand, is for patient benefit down the road. And we need to also address the current clinical trial or studies with the focus of the variables to be tested is the quality of life of the patient and the functional status of the patient. Sometimes patients ask me questions like, what kind of a benefit do I get in this research project? To be honest, a lot of times we cannot promise patients, say there's direct benefit from doing the research because we can give you this and give you that. That's not practical. But get involved with the researchers. Usually you get a better understanding about your own symptoms and how that part of the symptoms relate to the disease. I'm not saying you don't understand your disease. I'm talking about with more interaction with the researchers, with trying to understand a question that really provide a better background and better understanding about such kind of conditions. And the overall, for the whole community, is a better understanding about the disease entity. So it may not be for you, for example, for Parkinson's, it might be for the whole Parkinson's as a whole entity. And these understandings can be quite helpful for the healthcare decisions and to improve quality of life for everybody with Parkinson's disease. And with what we know and what we are going to know from these research results, that can guide further improve the studies and the treatment options for the patient. There are different kinds of research and there are different levels of research. I don't need to get into too much details. So for people heard about, these days, everybody have a whole bunch of access to different websites. For example, from Parkinson, Alberta, you guys do Michael J. Fox webinars and educations. So everybody is familiar with the concept of research. For example, most of the common ones are observational studies. These are the surveys, the database, and the follow-up over the years to see the course of the disease and those type of things. And there is a measurement of quality of life as well. There are experimental studies. The most common see are the randomized clinical trials for new drugs, new interventions. And not all of the intervention studies are randomized. For example, if there's a group of people with deep brain stimulation, you can't really randomize these people, but doesn't mean the level of the study, level of the evidence is poor. And there, people can all pull a whole bunch of papers and analyze the validity of the studies, and then make a systemic review and to do guidelines. So all of these are examples of research. So that's a bit background about what are the clinical research are. So what I'm going to talk now is what is happening at U of A. In our Parkinson and movement disorder program, right now we have 7 physicians, and also you guys probably know we are truly an interdisciplinary program. We have occupational therapy, physiotherapy, social worker, speech language pathology, well, that's shared. And so everybody put their effort in, and we have different expertise, a different interest. So for example, right now for the observational studies, Dr. Kamcholi is a PI, Canadian Open Parkinson Network. So there's 2 steps of the survey. So basically it's a survey. And Dr. Miyazaki, who is our director, gave a talk, I believe, on April 1st. So she is the site PI for the Parkinson Outcome Project. This is quite a large project. We have lots of people actually enrolled in this project. It's an outcome research, and we keep the clinical data so far among 5 countries and multiple sites, more than 13,000 participants. And we're looking at like the treatment, medical treatment, surgical treatment, and the candidate for different treatment, exercise regimens, physio, and all that, and including caregiver burdens, things like that. So these are observational studies. There are also interventional studies. I think it might be easier to do this way. So I take a couple doctors and list a few of their studies, just give an example to show what different kind of things they do. For example, Dr. Miyazaki, as I said, she's the director of our program. Before she came to U of A, she works in University of Toronto. She established the palliative care program over there. So one of her expertise and practice interest is overall well-being of the patient in Parkinson's disease and neurodegenerative disease, and focus on quality of life, spiritual care, and advanced care planning. So this is a study published very recently. So I pulled a couple of studies from her publication in 2019. Kenneth is a PhD student. And so in this HOPE study, I put a link over there. We have a link on your website, I believe. So this is about strength, hope, and the resourcefulness program for people with Parkinson's disease. We enrolled 30-some patients with the diagnosis of Parkinson's less than 5 years. And they have to attend a hope-based group session for 4 weeks, and then assess their health-related quality of life immediately after the group sessions, and then 6 weeks later. And such exercise showed a quite significant improvement in their quality of life. And so the PhD student did his thesis based on such a study background. So that's one of the examples for her focus interest. So focusing on people's behavioral modification and how to strengthen their, their spiritual care and hope, and to strengthen the coping strategies as well. Another focus in Dr. Miyazaki's study is the advanced care planning. Most people coming through the clinic, and we touch on goal of care, particularly if we are dealing with people who is 15, 20 years into the disease and with other mobility, mortality, caregiver burdens. So we talk about that. It's a nice thing. You can plan what you want particularly. So this is the qualitative study for 30 patients and their caregiver. When patients are giving options and that they can define their own advanced care planning, and that their plan, each person can, their goal of care can vary significantly. And by defining such a care planning in advance is quite helpful. And we use the palliative approach. And, you know, I found it interesting. You know, palliative was perceived as close to death in the past, the cancer patient. But over the past few years, with introducing this whole approach, group interdisciplinary approach, people understanding more and more with chronic disease, such as Parkinson's disease, actually palliative approach is a good approach to improve comfort measures and the quality of life. And our palliative clinic or complex neuro clinic is very successful since Dr. Miyazaki joined the program. So this is part of the work she's doing with advanced care planning. So, and this part overlap a little bit with what we do, and Dr. Miyazaki and her colleagues in University of Toronto did this part of the study. So advanced care planning usually is not discussed with the DBS patient. Our looking at the DBS patient, usually they are younger, they start to have some motor complications, so they go through surgery and the surgery can improve their symptoms significantly. However, giving this all the truth, people still age. Even they go through the DBS at 55, when they are 80, the complications still occur. So with this cognitive function can potentially be suffered from DBS, and talking about these planning before DBS actually is not a bad thing. It's very beneficial. So they establish a framework about the advanced care planning before DBS, and was perceived pretty well as well, although it can be pretty challenging in certain cases. Along the same line, this is a part of her practice in the complex neuro/palliative care. Plan for a comprehensive roadmap for the patient and the patient caregiver. And no single patient is the same, and no single disease, although it's all Parkinson's disease. I kind of say Parkinson's disease is like a package. Each person gets a different package, right? So we look at the patient and ask them, so as the disease progresses, and what kind of a roadmap you want to expect, both from the patient side and from the caregiver side. And there are different themes, and this study explores the different themes of the roadmaps. So all of these, I don't want to get into the detail about, I'm not the expert in such. All of the examples I try to give is to show a different focus in research, and all of these is about the philosophy of care and the quality of life in Parkinson's care for chronic disease. So that's part of Dr. Miyazaki's research focus. And I think Dr. Miyazaki, when she talked about caregiver issues April 1st, she might have touched on that. So there are a whole bunch of caregiver characteristics with caregiver burdens with Parkinson's disease. So when we look at a patient, we don't just look at the patient, we also look at the patient and the family as a unit, And the patient caregiver burden is an issue we need to address as well. So that's the wellness. It's not the disease, it's the wellness of a person. And another one for the spiritual care. If people come through our clinic for her palliative care or complex neuro clinic, we have a spiritual care Caroline. Caroline did a PhD student with PhD thesis with Dr. Miyazaki as another supervisor. And I believe she's going to do a talk or talk to each individual patient if they're interested down the road in this month as well. So that's a part of it. And the spiritual well-being has been shown quite beneficial as well when discussing in this whole complex neuroclinic settings, and they published a large paper regarding that. So that's Dr. Miyazaki. She, as I said, each person has a different expertise in their practice, and I just want to show, in our clinical practice is not very just science focused, and the patient well-being, spiritual, healthy health, and the overall, family caregiver burden, that's all considered. So this is more a new model, patient-centered model to deliver care. And so we integrate the patient care into the research programs. Any question regarding that part? Okay, now I'm going to talk a little bit Dr. Camatroli's study, again, just to give a couple examples. So Dr. Camatroli is the co-director of the program, and he's also the director of the cognitive clinic. So his research interest is in biomarkers for neurodegenerative disease and gait for Parkinson's disease. He has been doing gait analysis in Parkinson's disease since he was a postdoc fellow in the States, in Oregon. And one of his biggest focus is the cognitive aspect of neurodegenerative disease. We have been running a large cohort of a campus. This is comprehensive assessment of neurodegeneration and dementia. This is Canada-wide study, one of its kind. In U of A, we so far recruited over 100 patients. And the study look at the cause of the neurodegenerative disease. A big part is Parkinson's disease, the treatment and the prevention. And over 4 or 5 visits, the participant will be given information on their overall health, nutritional status, sleep, the well-being part. And we do a detailed history and physical examinations and neurological examinations. The exam is not just like the regular neurological examinations. Actually, it's quite detailed, both hearing, vision, smell, and the walking, and like the full domain. And there's a 3T MRI of the brain, and there's some lab test for blood, saliva, urine, and optionally for fecal and cerebrospinal fluid. From the campus database across the country right now is, as far as I know, last time I looked, I think it's about 500-600 imaging collection already in some of the samples. And there are already a few publications come out, like this one. Because the patient in neurodegeneration, they have frailty. So the analysis, Dr. Camatroli is one of the authors here, they analyze the frailty prevalence in this whole cohort. And there are gait parameters, gait analysis as well. One paper was out in this regard. And as I said, Dr. Kamacholi's interest is in gait decline and cognition as well. So they have this study on gait decline and fall risk in people with a mild cognitive impairment. That's before, it's not, mild cognitive impairment is not dementia. So they want to see the link between the gait and fall risk in this mild cognitive impairment and the recurrent fall and the gait decline does indicate a further cognitive decline from this study. And we all know that Parkinson's, there's a difference between different genders, more male dominant. So they did a large analysis from the current available literature to see the difference between the sex-specific deficit in that domain as well. With Parkinson's disease, it's not uncommon to see when you get up, blood pressure drop because of the autonomic system change, autonomic neurological system change. We are all telling the patient to drink more than 2 liters of water every day and don't want to get your blood pressure below 100. So if the blood pressure is below 100, there is definitely, poor perfusion to the brain. So one of his projects was looking at also static hypotension and the dementia incidence. So what kind of link is there? So that's another focus, a couple foci from Dr. Kamacholi's study, just to show what kind of things we do. Dr. Sikorsky, she runs the DUIDOBA program. We have about 20 patients going through the program right now. And she was the site PI to look into long-term outcome of patients with DUIDOBA. And over the past 2 years or so, we have a study. She's the PI working with her research fellow to evaluate driving abilities for Parkinson's patient. And there's also another study for the outcome of the DUIDOBAs. It's a long-term outcome measure as well. I don't know how much you guys hear about driving. And from the clinical side, actually driving can be a big issue. We in Canada, from any place to the next place is pretty far. And people perceive that as a huge issue for their, independence. Every time we talk about driving is a very difficult topic. So her driving study has been helpful. But from a research perspective, we can only suggest the patient suitable or not suitable to drive, and we cannot make the decision that you should not drive. So that's the hard part. And so far, we haven't figured out the best way to do a driving evaluation. And from a research to the real practice, there is a difference. So this is more, for Dr. Sikorsky, this is a little bit more clinical than research. The DUIDOBA program, we have also the multidisciplinary clinic with the nurse working with Dr. Sikorsky and the GI doctor specifically to put the tube in. And we have our fellow doing the clinical assessment, and the patient have access to the OTPT, social worker, psychiatry. So the access to everything, basically. Over the past 5 years, as I said, we have 20 patients also with the follow-up. And we, between the DUIDOBA program and DBS program, we have 2 patients after DUIDOBA still has motor complications that they received the DBS. And there are a couple patients I'm sitting on the fence whether we should go to consider DUIDOBA as well. And there are more referral going on from the community. So for myself, as you introduced me, Sherry, I'm a DBS doctor in the program. My research interest is DBS for Parkinson's disease and the patient-centered decision-making and the clinical outcome associated with that. I'm also interested in the gait and balance part of Parkinson's disease and sensory perception deficit associated with the disease. And I do MRI research to look at neuroanatomical basis of gait and balance as well. And aside from DBS, we have been doing a couple other stimulators for the axial symptoms, namely gait and balance. So a couple examples, some of the patient might done this before. So when they refer to the clinic for deep brain stimulations, before a full consult is done, my nurse, Michelle, is going to run this app. So the app is called a patient-centered decision-making app for DBS in Parkinson's disease, basically. And there's different pages, and you run page by page, entered all the symptoms. So left side tremor, right side the stiffness, gait and balance issues, and there's a non-motor part, memory, for example, anxiety, and poor sleep, blah, blah, blah. And then you read which symptoms bothers me the most and which symptoms I want to treat. And most patients want every symptom to be treated, but that's not practical. So we ask them to rank the top 4 motor, top 4 non-motor. And if the symptoms such as a tremor, slowness, stiffness are what they pick, clearly they have a very good outcome from deep brain stimulation. However, if the focus is on gait and balance, for example, and the speech, swallow, and a ton of non-motor, the sleep features, depression, those won't be a good choice for deep brain stimulation. I don't give this answer. So the answers are pulled from the literature, from multiple studies. So, and I explain to the patient, this is predicted response rate from all comers, and patient will see this. They put the information, their symptoms in, and that they will see the predicted response to see whether this is worse going through the deep brain stimulation, the brain surgery. So we have 62 patients going through that. And that is, in my mind, that's an important part to assess patients' expectation, their expected outcome down the road. And indeed, with our follow-up, these patients had improved the quality of, perceived quality of life compared with the people who didn't go through the app. And there are a couple editorial I wrote along the same thing with other cardinal studies over the past year. Another interest I have is the imaging studies. So there are different locomotion centers in the brain, and we do analysis and then talk about, I try to analyze which structure are more related to gait and balance deficit. And along the same line of imaging studies, one of my collaborators in China, they have fancy scans and they have lots of money. So we only have a 3T scan, they have a 7T scan. So it's the 7T high resolution scan, they can identify a very detailed structure. So we analyzed multiple issues. This one is actually just one example of the vascular space and the perivascular space. Like you have a bigger vascular space and tiny mini stroke, may not even be stroke, can correlate with tremor and the gait subtype. One more thing, some of the people went through our clinic may have done. So we look at the visual deficit. A lot of people in Parkinson's disease actually report they don't see the shape, the speed the movement well enough, this clearly has an impact on the mobility part. So we use a newer and a more physiological tool to assess the 3D vision. So that's, for example, on the monitor, and you have 3 squares, and at different spot, different distance and angles, and look at the square and tell me which one is closer this way. And we have a machine attached to the monitor here, and like this one. I don't know whether you can see the mouse. Attached to the bottom of the monitor can assess eye movement as well when different target pops out. So we analyze the 3D perception deficit and the eye movement change in Parkinson's, and this might be a marker to correlate with the disease severity. So these are the couple of things. That's just the results. No point of showing that. These are a couple of things I'm doing in clinic, a little bit more imaging and DBS focused studies. Dr. Sankar, Tejas Sankar, is our functional surgeon. He does the surgery. I don't do surgery. I do the programming. So we teamed up for the DBS program. One thing we have done is the spinal reflexes as a biomarker for Parkinson's in DBS. So the study is about to do like attach an EMG lead to the muscles, and then the tendon reflex, if you stimulate that there's a tendon reflex. So Parkinson's such reflex is abnormal, but with the medication and the DBS, it can improve, it can restore the abnormal reflex. So that's for the people off stimulation, off medication, and then we give medication, give stimulation, we see the change. We move one step forward to surgery. So when we put the electrode into the brain and the test at different spot before the electrode hit the target, and after the electrode pass the nuclei, and it doesn't suppress the abnormal reflex, only right in the target is suppressed the abnormal reflex. So in this way, we think that spinal reflex can be a good biomarker to indicate where exactly the lead is. So to confirm the lead location during the surgery. And right now we are also doing the similar kind of recording when I program the patient for the first time they come from after the surgery, and we're doing that. And actually, Dr. Sankar also does some imaging study. I didn't think I can finish everything, so I cut some of his slides on imaging. And I think people probably more interested in research, like a behavioral research related to deep brain stimulation. So one thing he's doing right now is on decision making. So we have a 3 group of people. People receive ST and DBS, and people had DBS, no DBS, just on medications, and a control group. Usually we just ask the family and friend to be the control. And so this is like on iPad, and you ask the patient each time you can bet this much money, right? And you click left and right. It's a very simple game, left and right. If you click the left side, for example, you win $10. So what's the next time you click? So this is basically is chasing a winning behavior or chasing a losing behavior. Is that a compulsive behavior associated with ST and deep brain stimulation? So it's just the behavior analysis to compare with people who didn't have a DBS. So it's like 10 minutes gambling game, but there are, we do it on DBS, off DBS, and then we do a cognitive assessment. So this is one of his research students' neuroscience thesis, and He just finished that part of the thesis. So research is not just a few professors sitting there and think about what I can do for the rest of the year to write grant or things like that. Research is a team approach. The reason I say so is, for example, in our program, Jennifer Krista, she is our occupational therapist, and occupational therapist more looking at people's function. So what she has been doing, and she's looking at an option of starting from an analysis of all the papers, the literatures. So people with Parkinson's tend to have micrographia, meaning the longer you write, the smaller the letters is getting, right? So her analysis and one of her projects she's trying to do is to use lined paper. So people, like, at least when I was a kid, we have to write, but I wrote Chinese back then. We have to write within a square, and you need to pretty much fill the square. So if patients are given lined paper, you're supposed to write within the line, and that might improve. It's just like a gait training, right? You have to think about big and big and big steps. So with such kind of training may improve. And Jennifer and Dr. Miyazaki also talked about calligraphy. So to see, you know, training the different type of writing habit may improve micrographia as well. So that's basically for functional improvement. So to come back to this diagram, we are doing clinical research. There are different forms of clinical research, and it's not out of the blue. We just decide to do research, and it's always a process. It's a continuum from a bench research to where we are to translation to clinical practice is a lot of effort. And this effort actually is more from the patient, from your side than from us, because we are having the same goal, and the goal is to improve outcome and to improve quality of life of the patient. And mentioned about a couple types, like most commonly is observational study and experimental study. I think in summary, I talked about some background about clinical research and mentioned a couple of things about why should I get involved in research. Give some examples about what we do in our program, try to help understanding a kind of a global idea. So research is not just about little mouse and not just the MRI and not patch a cell. Research is actually 360, and especially in the clinical world, we do research with the, you know, the goal of improve patient well-being, quality of life, and functional status. That's it. I'm happy to address questions.
Hi, everybody. This is Sherry. Thumbs up if you can hear me. Ladies in the panel. Good. Dr. Miyazaki, can we see your face again? Can you bring us back to your, can you bring us back off of your shared screen?
Oh, I don't have a shared screen. I thought you were talking to Dr. Miyazaki.
No, I'm talking to you, Dr. Ba.
Let me go back. I thought I'm still sharing.
You are viewing Dr. Ba's screen. Can you close out of your shared screen? Down at the bottom there. Nicola, am I telling her the right place?
Yeah, just down at the bottom,
It's
or at the top, there's a viewing option and you can...
I will call my technical support. Give me a sec.
Dr. Ba, you're just about there. It's up at the, there's a green button up at the top of it. Share screen is right down at the bottom in the center. On my side it is anyway. Can you see it?
So stop share screen.
Right.
Oh yeah, right there. Gotcha.
There she is.
You're welcome.
Thank you so much.
No problem.
All right. just wondering if we have any questions. One question that we did have was, do you know what's happening with the deep brain stimulation surgery in Calgary in Edmonton? It was heard that, well, prior to the coronavirus, that there was surgeries that were not going forward right at this point?
First, that's not a research question, but I can address that. I don't think in the Calgary program is officially closed. For a while, I know if the program was on hold. I never heard about the firm, like no longer operating. And Dr. Kish is a very skillful surgeon. And at the same time, they are doing some like focused ultrasound surgery as well. We didn't take a Calgary patient for a while. We don't mind to see second opinion. The reason for that is because both team are parallel team, right? And we don't have a reason to take a Calgary patient, especially if our patient, is already waiting pretty long, and people will, it's a resource issue, right? We have one surgeon, they have one surgeon, and they have the same size of the program, so
that makes sense.
Not too much, not too much beyond that.
Thank you so much for answering that question.
Yeah, no problem.
Well, I haven't got any other questions. Does anybody else have any questions from the panel or from our attendees? I don't see any in the chat. But I do want to thank you. I know all the different research topics that you were talking about. These are all very pertinent issues with the people that we serve in our regions throughout the province, and it's really hopeful because we can see that concerns are being heard and that people are really being taken care of, and that to us, for myself, that really means a lot, being able to work as part of this team that are serving the people in this province. And much gratitude goes out to you and your team. Thank you so much. And we've heard a lot about the research. I've got a few of my clients out in the Lloydminster region that are participating, and it's creating a lot of hope. I really appreciate it. And thank you on behalf of the people we serve.
Right. People actually pretty keen to get into research.
Absolutely.
Because it is opportunity. They feel it's opportunity to know the right people to not to directly address their question, but even through the process, it is like an opportunity to learn. And when we say to address patients' interest, they have the right to know what's going on. What is the newest? What is the best? It doesn't mean research is the best, but that's the opportunity to understand what's going on, right? And the newest technology available. So yeah, I think it's a fair thing, at least to let them explore and give everybody the equal chance.
And it's great because they feel that they've got power over a little bit of power over the disease rather than having that taken away from them. And as we say, stop a thief, and so many people feel that way. They've lost so much, but this is a way of them participating and taking some of that control back. It's very empowering for them. There's a question here: is the whole patient approach for research just for the U of A, or is that for research in general for all Parkinson's?
There's a whole patient-centered approach. Actually is for medicine, for practice of medicine. So it's not just for research, it's not just for Parkinson's, it's for the whole medical practice these days.
It's good to hear. Very good to hear. I don't see any other questions. Does anybody else have anything on the panel? Questions, thoughts? Is anybody interested in making an end comment? We're good? All right. Well, we really want to thank you again, Dr. Ba, for joining us. And it was really great seeing you in person. I've heard so much about you.
Thank you. And I apologize